Good afternoon, Facebook family. I'm Sandria Washington, executive editor of blackdoctor.org. And today, Team Black Doctor is on the road. We are coming to you live from the University of Michigan. September is Blood Cancer Awareness Month, and African Americans have the highest risk of myeloma, a form of blood cancer, the highest risk of any race or ethnicity in the world. And joining us today is one of the nation's leading multiple myeloma experts and assistant professor of hematology and oncology here at U of M, Dr. Craig Cole. Thank you so much for joining us, Dr.
Thank
Cole.
you.
It's a pleasure, it's an honor to have you here.
Heavens. Thanks.
Yes. So let's just start. What exactly is a blood cancer? What does that mean?
Yeah. So the immune system and the blood comes out of the bone marrow. So the bone marrow is the blood factory and part of the immune system. And just like people can have cancer of the lung or cancer of the prostate, you can have cancer of the bone marrow or of the blood factory. And so we call those the blood cancers. The bone marrow makes the white blood cells, which help fight infection, the red blood cells, which help give you energy, and the platelets help make blood clots. And they also have lymphocytes, which help to fight infection, and plasma cells. And any of those cells can turn into cancer. And the common ones that you hear about are leukemia, which is a cancer of the white blood cell coming out of the bone marrow, or lymphoma, which is a cancer of the lymphocytes, the immune cells coming out of the bone marrow. But another type of cancer that isn't talked about as much is multiple myeloma, which is a cancer of the plasma cells that come from the blood factory or the bone marrow.
Now, why is it so important for African Americans in particular to know about multiple myeloma?
Yeah, the really interesting and one of the unique things about multiple myeloma as compared to the other blood cancers is that it affects African Americans twice as much as any other race in the United States and any other race in the world. So it's the eighth most common cancer among African Americans, and it is one of the top blood cancers in African Americans. So it does affect our community disproportional to other races.
And so when I hear you say, it's the eighth most common cancer in African Americans, we have twice the risk, it's startling to me that we don't hear as much about multiple myeloma. Why do you think that is?
Myeloma is a tough disease to talk about because you have to know a lot about the bone marrow, you have to know a lot about the blood in order to describe it. And lymphoma or prostate cancer are much easier to discuss. But in order to talk about myeloma, you have to talk about the bone marrow, and sometimes that impedes a discussion about this particular disease. Also, there wasn't really good treatments for myeloma for decades, and so people didn't talk about it because there wasn't any good treatments for it. But now that we have good treatments for it, it's getting really exciting in how long people are living with myeloma that we're trying to raise awareness for myeloma.
So what do you tell your patients who are living with multiple myeloma or even their family, their caregivers? How do you explain it to them to help them explain it to other people?
That's a really good question because in order to talk about having cancer, it is already distressing for people to be diagnosed with a cancer, and then to be unable to discuss their cancer with their family is really difficult. And what I tell my patients to say is that, just like I mentioned a bit before, that inside the bone marrow there are blood cells, and one of those blood cells is the plasma cell, and myeloma is a cancer of the plasma cell that arises from the bone marrow. So myeloma means marrow, and multiple means that those plasma cells go to multiple bones and affect areas and can cause pain. So multiple meaning multiple bones, myeloma meaning from the bone marrow.
Now, someone who's living with multiple myeloma, what are they experiencing in their bodies? So kind of describe for us, what does that look like? What does that feel like?
Now, when people are diagnosed with myeloma, they can, I like to, or when they have symptoms of it, I like to kind of remind people to think back. And the letters BACK can describe the symptoms of myeloma. So B stands for bone, and the multiple part of myeloma means bone lesions, that the cancer cells, the plasma cells, leave the bone marrow and go to the long bones like the arm or the leg or the ribs and can cause bone breaks and pain. So a common feature of myeloma is pain in the bones, back pain, rib pain. So that's the B. The A in back is anemia. So in anemia is when your red blood count is low. And again, the red blood cells are the ones that carry oxygen, give you energy. And so when you're anemic, when your red blood count's low, because the blood cells can't get out of the bone marrow because of the cancer, then people can be fatigued and be really short of breath, and short of breath when they do activities. So that's the A is anemia. C stands for high calcium, that the blood calcium level can get high. So because myeloma will go to the bone and cause bone destruction, holes in the bone, and bones where we carry calcium in our bodies, that if the myeloma is destroying the bone, it can raise the calcium levels. And when people have high calcium levels, they get really confused, that they get really sleepy. They'll usually have frequent urination and really thirsty, but it's the confusion that's really the hallmark of high calcium levels. And then the K stands for kidney. So in kidneys mean that the myeloma also produces a protein that is usually used to fight infection. But when people have cancer of the plasma cells, that protein can get stuck in the kidney and cause kidney failure or kidney problems. It's not enough that it doesn't change people's urine, although some people can have kind of a foamy urine when they have myeloma. But by the time that it can cause the filter of the kidney not to work very well and can cause kidney damage. And so I tell patients that if they have, that when they talk to their doctors about back pain or if they have kidney problems, that they should, think about BACK, B-A-C-K, which are the signs and symptoms of multiple myeloma.
Now, is it difficult to get a proper diagnosis for myeloma? Because I'm just hearing some of the symptoms, fatigue, maybe extreme thirst, things like that, and it could be something else. So is it difficult for people to get a diagnosis?
No. Actually, to ask your doctor to screen for myeloma is pretty easy. There are 2 tests, and sometimes 3 tests that you ask for. One is a protein test, and so the starting test, the easiest test, is to test for a blood protein level, because when people have myeloma, those plasma cells produce too much blood plasma. It raises the protein level in the blood, and you can detect that on a blood test looking for protein. The specific test is something called a protein electrophoresis, or SPEP. And the SPEP will find the protein in the blood. And then the last test is a urine test, so a urine protein test. And so the 2 tests that you can ask your doctor about if you're concerned about myeloma is the protein test, or the SPEP, and the urine test for blood protein.
And who's most at risk? Do you typically see this in maybe young adults, or is it older adults? Who should kind of be on the lookout for?
So it's older men. So myeloma affects men more than it affects women, and the risk of myeloma increases with age. And at the age of 85, an African American man is 125% more likely to get myeloma than any other groups.
Wow.
And so especially our older population is at the most risk, and we should watch for it the most.
Now, what does treatment look like? So if you've been diagnosed with multiple myeloma, what are your treatment options?
So that's one of the biggest changes that have happened with multiple myeloma. Is about 15 years ago, we had nothing but chemotherapy, and the treatments didn't work that well, and they had lots of side effects. the treatments that we have now, for the most part, we don't use any chemotherapy to treat myeloma. That all the drugs that we have now are targeted agents. So they're drugs that are specifically built to treat myeloma. And they're pills that are specifically built to treat myeloma, and a shot that does nothing else but seek out those malignant plasma cells and leaves all the other cells alone. The component that we have of the therapy that has been consistent over the years is using steroids, and not the anabolic steroids, but the steroids like cortisone or prednisone that we use to treat asthma and treat types of arthritis. And so the treatments are now targeted. They have less side effects, and they really don't require hospitalization. Like, they don't require hospitalization at all. They're all outpatient treatments.
And I know you're really excited about these newer treatments because it's increasing survivorship. What is the life expectancy with some of these newer treatments?
Yeah, that's a really good question, because in fact the life expectancy is growing faster than we can actually kind of predict it.
Wow.
And so the survivor, how long people would live with myeloma years ago is pretty easy. It was just 3 years. The advances in myeloma are coming so rapidly that it's hard for us to even predict how long people will live with myeloma, because they're breakthrough after breakthrough after breakthrough. For your average patient with myeloma, we now know that at the very least that 85% of patients will survive 5 years. And that is looking at some of the treatments that we just had 5 years ago. We've already improved upon that with research that we're doing today.
Wow, that's exciting. That's good. Are there any barriers to making sure that people are getting these newer treatments, and how can we make sure that African Americans in particular are getting these newer treatments?
And that's the one thing that we're really trying to work on is that in the upshot about all these new therapies is how well they're targeted, how they have less side effects. The barrier to it is that these drugs can be very expensive. The fortunate thing is that there are programs and societies and grants that are out there to help pay for the medications for people who can't afford it. And thank goodness, there are foundations and non-for-profits that know that myeloma treatments cost a lot of money, and you can seek those out, and really to have your doctor help you find those ways to pay for the medications. And I'm very fortunate that at the University of Michigan we have a whole office that looks into grants and looks into ways to pay for people's medication, because we know that they're expensive. The biggest barrier is that patients feel that they don't have any hope to figure out how to pay for the medications, that before then they get the prescription and they get a denial, that they just leave it. If you get a denial about a drug to treat cancer, especially for myeloma, we can find a way to have somebody help you with that payment.
So is the best course of action for them to maybe try to connect with organizations or work through their doctor?
Yeah, work through their doctor, but also, I always recommend getting second opinions at some of the major medical centers that have some of the resources to go look at some of the non-for-profits and some of the foundations. There's foundations like the Chronic Disease Foundation, and they help support drugs the cost of drugs for many different types of cancer, including multiple myeloma. But getting a second opinion from a major cancer center and finding out the best way to have the medication paid for, and not just taking the answer of no, you can't afford this. Where there's a will, there's a way, and we can usually find a way to get these medications paid for.
And so we talk a lot on our site about clinical trials and, of course, getting more African Americans in clinical trials. How do clinical trials play into multiple myeloma and hopefully finding a cure? Because right now there isn't a cure.
Right now there isn't a cure for myeloma. For right now what we do, and you ask what does myeloma therapy look like, Myeloma therapy is usually long-term treatment. I mean, we can't cure myeloma today, but we can control it so that it doesn't interfere with people's lives. The one, again, hallmark about myeloma is how it affects African Americans twice as much as other ethnic groups, and which means that we really need clinical trials to find what is the best therapy for everybody with myeloma, but especially for African Americans, because the new therapies are now more biologic. The new therapies aren't chemotherapy anymore, and people of different races have different biology. We're not all built exactly the same, and so we have to know how myeloma works inside African Americans in order to treat it better, in order to hopefully cure it someday. So it's really important for African Americans to be involved in clinical trials in myeloma. The other thing is that the clinical trials give you the best therapy too. Because there have been so many successes in myeloma treatment, that we're no longer having to really experiment and use unusual or new drugs in myeloma. We're given the opportunity to be able to choose the clinical trials that we want for multiple myeloma, and the clinical trials are safer than really they've ever been. And so going on a clinical trial, at least for multiple myeloma, it gives you the opportunity to get the drugs for free in many cases, and it also gives you the most cutting-edge therapy available for myeloma.
Now, can you talk a little bit about how does a clinical trial work? Because I think some people, we don't know what happens, but there's a stigma, there's a fear. So can you just talk a little bit about what someone could expect if they did participate?
Yes, and so so some of the myths about clinical trials is that you'll receive a placebo, or that you won't get therapy for your cancer, and that doesn't happen. That you can't give somebody a placebo for cancer. You can do that for other conditions, but for cancer you can't give a placebo. So there are no placebo clinical trials in cancer. They have to offer you the best available therapy and the experimental therapy or the investigational therapy, but there's no placebos. The other thing is that the other myth is that people will be experimented on, that it's not safe. And more now than ever, the clinical trials are incredibly safe. The FDA has multiple safeguards in order to make sure that clinical trials are safe for people and that they have merit, that there's clinical trials that will actually benefit the community. Also, at each institution, there are review boards to make sure that the clinical trials are conducted safely. And so clinical trials do not even start unless they're safe and have merit. And so there isn't anyone being experimented on. And the last thing is that, and probably one of the most important things, is that people don't feel that they're eligible for clinical trials. And now there are clinical trials for myeloma. There are clinical trials across the spectrum. Before people have symptoms, when people have symptoms, when people have after therapy, when they're on maintenance therapy. Across the spectrum, there are clinical trials for patients with myeloma, and in general, there are more and more clinical trials. The number of clinical trials in the United States has boomed because they're successful, that they're showing promise. And the more promise in clinical trials there are, the more that people are involved in it. And so I would strongly recommend being involved in clinical trials.
And how long would a typical trial last?
So usually what happens when people enter clinical trials is that they will meet with a doctor and go through something called a consent form. And the consent form outlines all the details of the clinical trial, including who's going to pay for what will be covered, making sure that the medications are covered in clinical trials, and the operation of the clinical trial. And the consent form should be in a language that you understand, and that you give an adequate time to go through the clinical trial before you sign it. After you sign the clinical trial, then there's a period called a screening, where they make sure, it's a double check to make sure that the clinical trial is safe for you. And after the screening, then people enter the clinical trial with the medications or the laboratory testing. And the clinical trial can last between 1 year to the entire lifetime. And the one benefit about clinical trials is that it can last your entire course. And when it lasts your entire course, you're always going to have not only your nurse and your doctor watching out for you, but also a research coordinator. And so every clinical trial has somebody who coordinates those projects for you, and they are an additional set of eyes, an additional helping hand when you're involved in a clinical trial.
So you're getting that extra, almost personal care during, living with this condition.
Absolutely.
During the trial. Yeah.
Absolutely. And there's been research showing that people who are in clinical trials receive better health care because they have not only their doctor and nurse, but then they have a coordinator that is watching out for everything that they do. And so it's again, with our patients, some of their closest allies in our clinic is the research coordinator.
So beyond the clinical trials and the newest medications, are there any things that someone living with multiple myeloma can do to help prolong their life or just cope better with multiple myeloma?
Yeah, so one of the probably the most important things about coping with myeloma and living with the disease is to be empowered. And that's not only with myeloma, but that's with any condition or any cancer, is to be empowered, to be informed. The days of having the days of patients asking me, well, I'll do whatever you tell me to do, doctor, those days are over because there's so many choices available now. There's so many options for patients that you can really choose what's the best therapy for you. When we used to have only 2 treatments for myeloma, there wasn't a lot of choices. There wasn't a lot of reasons for patients to be empowered. But these days, with there being 8, 9 different choices and options for myeloma treatment, the patient has to be empowered enough to say, this is what I want in my care. These are the goals that I want to meet. And we can then structure the therapy around you. So one of the most important things is to be empowered with this disease and knowledgeable. There's information out there on the treatments for myeloma. You can ask your doctor about the websites and getting information on the disease. And there are support group meetings across the country for people with myeloma, and where you can talk to other patients that have the disease. And it gets, as you're more empowered with the disease, then you can make more decisions for yourself. When you make more decisions for yourself, then you feel better about yourself because you have assumed control.
And I was just going to add to that. So people are becoming caregivers, it seems, younger and younger, or sooner than expected. Do you have any advice for the caregivers for someone who's living with multiple myeloma?
So the first advice for the caregivers is take care of yourself. Is that you have, in order to take care of somebody, you have to be healthy yourself. And so the big thing for caregivers is to get enough rest, because that will then help the person that you're caring for. The other thing is to be empowered and listen. That the one trick about being a patient is that sometimes people are in shock. That when they hear a diagnosis of cancer, or they hear changes in their blood counts, sometimes they can't hear that when they're at the doctor's office. And so having another set of ears always helps. So being that person in the room that is advocating and taking part in that clinic visit is kind of critical. And then to be an advocate for the person who you're caregiving for. Sometimes the parking can be a problem at a hospital or a clinic. Advocate for that. Advocate for when my grandmother had cancer, they didn't have parking for her, and so I went to the clinic director, and I said, we need some more handicap parking so I can get my grandmother to her appointment, or we need to have valet parking, and thank goodness that during my grandmother's life they had valet parking for her. So I would, you got to advocate for, the person who has the cancer may not advocate for themselves, and the caregiver can do that too. And being knowledgeable and empowered, that to ask questions, and I always tell my patients to ask questions and ask your doctor questions and question your doctor. That if there's a decision that's being made, ask your doctor. Says, oh, how does this work, or why are we doing this? And ask your doctor questions about, what are the side effects of this medication. And one other thing, I know I kind of running on, but one other thing is don't be shy. People need to know that one thing we know about myeloma is that 30% of myeloma patients won't tell their doctors that they're having problems with the medications that they're taking. They're afraid that their doctors won't understand, or there's no way to help. Well, there's no way you can help if no one tells us what's going on. And there are lots of different options again. So one important thing is if you're having a problem with the medication, don't be silent. Tell us so we can address it right away. And that's how you avoid long-term complications from both the disease and from the medications.
No, that's perfect advice. I want to see if we have any questions from our viewers. We definitely want to make sure we get to your questions as well.
Yes, we do have a number of questions. This is obviously a topic that is near and dear to the hearts and minds of our audience. Interesting comment here from Cynthia Ward Jackson. Thank you so much, Dr. Cole, for successfully treating my cancer. You're the best of the best.
Wow, Cynthia.
Well, thank you. That's very, very high praise.
Let's see. There's a question here from Sadiqa Wallace. She says, how will the candidate know what is safe? How can they check to make sure that the treatment is safe that they're going to be ready?
So for the trials.
Yeah, for the clinical trial. So yeah, that's a very good question. So the inside the consent form. So the consent form is the document that talks about the safety of the medication that's used, and it outlines everything about the potential side effects, the rare side effects, everything that can happen with the medication. And it is not the research person that puts that consent form together, but it's actually the FDA that goes through and makes sure that everything that can happen with that medication is listed in that document. And then people who, when the consent form in the clinical trial goes to the review boards at each hospital or clinic, people who are not doctors will review the consent form to make sure it's in a language that everyone can understand and that it's complete. So the first place to look about how do you know what the effects and the side effects, or how well that drug is known to work, is inside the consent form. The second thing is asking the doctor when you're sitting down talking about a clinical trial, is ask them, in your experience with this trial, what has been the side effects that you've seen? Because sometimes as physicians, as we conduct clinical trials, we'll start to get at least some idea of what potential side effects are more common that are on that list. And I think that one of the best resources is asking the clinical trial coordinators, the people who are at the ground level of the trial, the people who are closest to the patients, the trial coordinators, and asking. And the good thing with the trial coordinators is they are really specific to that particular trial. They're not doctors or nurses, but they're trained in just clinical trials. Okay. And so they're more like lay people, more like friends, to really tell you what's going on with the trial. And so the consent form, asking the healthcare provider, and talking to the clinical trial coordinator.
Here's another question from Piola Thomas. Dr. Cole, could diet and the environment play a role in getting multiple myeloma?
Well, that's a really good question. So we don't know how people develop myeloma. We know that it doesn't happen in children. We know that it is something a disease that arises as people get older. So you have to live a life in order to get myeloma. We do now, just this year, we found out that obesity, that the heavier people are, that obese people have a higher risk of myeloma, and that was just shown this year for the first time. But diet and exercise, we know that people that have healthy diets that limit processed foods, that exercise, even though it sounds kind of corny, it's true that your immune system, because myeloma is a cancer of the immune system, or of the blood, I like to tell people that every time you eat something that is really heavily processed, that your body has to really work and figure that out, and your immune system has to work and work and work. Instead of fighting an infection, your immune system has to figure out what's in this beef jerky,
this food, right?
In this food, and so having a fresh fruits and vegetables, a healthy diet, and limiting processed foods are a way that we know can slow down or maybe hopefully decrease the progression of diseases like this, and exercise too.
Now, to add on to her question, do experts know why we see a higher incidence, higher risk in African Americans? Is there anything to help explain that?
So we haven't found the real issue of how, or the smoking gun of why there's a higher risk in African Americans. There's some suggestion that there may be a genetic mutation that's associated with this disease in African Americans. But why do African Americans and people of African descent, anywhere, why do they have a higher incidence than other ethnic groups is unclear. Part of the reason for that is that we need to have African Americans involved in clinical trials to be able to figure that out. There's a nationwide clinical trial that's going on looking at the mutations in myeloma. Right now, there's 6% African Americans in that trial. Well, it's going to be hard for us to figure out why African Americans have that trial with only a 6% group. So that's why getting involved in clinical trials for a disease that affects us more than other ethnic groups is so important, because it will be able to answer questions like, where does this come from in African Americans? Why are we so much affected? Why aren't other groups affected? Is African Americans being involved in clinical trials?
Here's a question from Bianca Walker. Why is it that African Americans always have it worse?
Where to start?
So that's a big question. I think that there is a lot that has happened in this country where the genesis of that is over decades and almost and hundreds of years. The changes, the trick, I think, is that the changes are really at the footstep of African Americans having it worse, is that we are now becoming empowered. I mean, knowledge, this website alone is empowering people so that they don't have it worse, so that that, gosh, there are other people that have myeloma, that have prostate cancer, to be empowered to know about your disease, either blood pressure, prostate cancer, multiple myeloma. To be empowered already makes you rising yourself up to be able to make decisions for yourself and empower yourself. So are things going to be, is the idea of things being worse going to last forever. It is not. I believe that's not going to last forever. Just us talking about myeloma, raising awareness for myeloma, is already going to have people get diagnosed with this disease. I hope that they wouldn't otherwise find out about. And knowing that you can empower yourself to help make decisions can help, raise people up. And being involved in, I know I've said this a couple times, but being involved in clinical trials, being involved in the front lines in fighting cancer can bring people up. So that's the past. I could talk about the past for months, but the future, I think, is going to be better.
Here's a question from Angela Brightwhite, and it's a similar question by Deborah Evans. Angela asks, is it genetic? Deborah asks, if my husband had multiple myeloma, will my daughter get it as well?
Very good question. So myeloma is not genetic. So it is rarely passed down through family members, and it hasn't been seen in the African American community. We do know that if you have a brother or sister that has myeloma, the risk is slightly higher. But is this a disease where you have to worry about your children getting it? No. It really is a disease of exposures, that we get exposed to chemicals and pesticides and different infections throughout our lives. And this disease is really a disease of inches, that you get exposed to this and that and this and that and different things throughout your life. And then by the time that you're 70, you've been exposed to enough things that causes those plasma cells to mutate and become cancer. And so there really isn't a genetic component to it.
This is awesome. Okay, we've had a number of questions that Dr. Cole has covered earlier in the interview, such as what are the symptoms, how are they detected. Perhaps, Sandy, you could talk to our audience in terms of where they can go to get more information.
Most definitely. So if you are just tuning in, if you're seeing this a little bit late, this broadcast will live on the Facebook page and also on our website, blackdoctor.org. You can also go directly to blackdoctor.org and you can check out, we have a number of information sections on the site about multiple myeloma. So if you just go to the search bar, you can type in multiple myeloma and you can find all of our content on it. But this video, you can watch it from the beginning as soon as the broadcast is over at any time. And definitely share the link out.
And one last question, Dr. Cole, how can people get in touch with you?
Thank you. That's high praise.
Where can we find you?
But the University of Michigan Cancer Center. So the U of M Cancer Center has a website, and it has a link to the multiple myeloma clinic.
Really briefly, before I let you go, can you just touch on, just really quickly, bone marrow and bone marrow donations?
Oh, yes. So my multiple myeloma is one of African Americans are disproportionately affected by myeloma, but actually the most common blood cancer is in adults is lymphoma in African Americans, just by number, and leukemia and lymphoma in children, and the way that one of the tools to treat leukemia and lymphoma and myeloma is having a bone marrow transplant. And a bone marrow transplant is when you can give some type of chemotherapy to destroy the cancer, and then you receive a donor bone marrow to replace it. The one thing about bone marrow transplant is that people of different ethnicities have to match each other. So someone who is from Japan will only match a bone marrow for someone else in Japan. and people from the Middle East will only match people in the Middle East, and African Americans and people of African descent will only match people from African descent. Mm-hmm. And so, in order to find a match for a bone marrow transplant, and for African Americans that are around the world, around the country, that who need a transplant in order to survive their disease, they need a donor. Mm-hmm. And so, in the way to donate, the way in order to see about being a donor is really a mouth swab that they do the genetic testing to see if it's a match by just a mouth swab. And in order to donate bone marrow, so if you get called to actually donate marrow, no one does any biopsies. There are no big needles involved in donating bone marrow. The cost of donating marrow, if you're called, is all on the patient's insurance, so there's no bill to you. And when you actually donate bone marrow, they just it's like donating plasma. Mm-hmm. That they just put an IV in your arm, and they're able to filter out just the stem cells out of the blood and then donate that to the patient. Mm-hmm. So it's maybe about 2 hours, 2 hours out of your entire life that
to
can
help save
somebody else's life. Exactly.
I think that's an excellent trade-off. Well, we want to thank you, Dr. Cole, for sharing this information with our audience. Thank you for all of the work that you're doing here at U of M. We definitely appreciate your time and your expertise.
Oh, thank you.
We've got to talk again soon.
Yeah, we can do that.
Thank you all for tuning in. Again, September is Blood Cancer Awareness Month, so this is a perfect time to research, learn about multiple myeloma, and consider becoming a bone marrow donor. So we want to thank you, as always, for tuning in, and we will see you next time.
Thank you.